I'm realizing I should have taken my optometrist up on her offer to get progressives this last time. I think the worst part about my story is that it's not unique. Details aside, it could be anyone's story. I know this because I make my living talking with people just like me, regular folks without medical training. What we all have in common are examples of being hurt by the very system that's designed to care for us. I'm not talking about major medical errors. It's a hurt that comes from a slow, steady erosion of confidence in people and organizations. If there's one thing that makes my story a little different, it's that I spent the last 18 years working inside of health systems, trying to remedy the problems I experience as a patient. Similar. It's a process I liken to digging a tunnel with a tablespoon. And I think everyone in this room understands. In any case, this gave me the insight into why things are, and most importantly, what needs to change. And I'd like to share with you 3 lessons that I've learned. Lesson 1, efficiency has been allowed to supplant empathy. My first experience with this came in late summer of 1991. After battling what was assumed to be 2 illnesses all summer, it was called whooping cough, and then an unknown blood disorder that initially was diagnosed as syphilis. And I remember saying, no, I think Al Capone had syphilis. I do not. The next time it came back as potentially a blood cancer. And finally, I received a call at my office temp job from the doctor's nurse on a Friday afternoon. The doctor determined, she said, that the whooping cough was pleurisy and that the blood disorder was antiphospholipid antibody syndrome. So you likely have systemic lupus. Antiphospholipid antibody syndrome is a clotting disorder. She said, this means you have a high risk for stroke and you likely will not be able to have children. I was stunned. My first question was, am I going to die? She said, I don't know. The second question was, what do I do now? And she said, the doctor is away until Tuesday. You can answer your questions then. I was told to make an appointment to follow up with rheumatology, and the next available appointment was 3 months away. Another experience came in the winter of 2001, and I actually find this one kind of humorous. I'd just given birth to premature twin girls. The pregnancy was planned, the twin part was a surprise. I delivered 6 weeks early because I developed HELP syndrome, which apparently is more common in patients with lupus. One day following delivery, I developed blood clots in the incision. I'd had an emergency C-section, and so it was reopened. It was packed twice a day. I was on a morphine drip as it was very, very painful, and it was made worse by my frequent vomiting due to the medication I was on to treat the HELP syndrome. At some point, the staff wheeled my hospital bed into the neonatal intensive care unit to see my newborn twins. At this point, my family and my husband had been told that my condition was serious and there was a chance that I may not recover. The NICU doctor began educating me about my girls. The process was captured on video by a family member. He delivered the requisite detailed education directly to me. I looked back at him and blinked slowly. Once or twice I nodded my head, and at the end he asked if I had any questions, and I said no. I have no memory of holding my girls for the first time, nor do I ever remember speaking to him. In both cases, the providers had news to deliver, and each delivered it efficiently. Both got to check the box. The problem was they did so without showing empathy for their audience. The first case was a stunned college student, and in the second, it was a drugged, sick, new mother. These examples and others like them made it hard for me to trust the people in the healthcare system, trust that those in the healthcare system would do right by me. Lesson 2, information silos continue to stymie care continuity. I accept responsibility for managing my chronic illness. It requires work on a daily basis. My medical records are evidence of that work. When you have a chronic condition that's not very well understood, the past becomes your crystal ball of sorts, a source for clues about what may be ahead. When I switched doctors in the late 1990s and early 2000s, I dutifully carried reams of paper records between providers, knowing they may never be looked at. When I switched doctors in the electronic health record era, I expected a much different experience. Insurance changes necessitated that I switch among 3 different health systems between 2013 and 2017. While systems A, B, and C all use the same electronic health record, Epic in this case, my records were never integrated by the receiving system. They remained in a quarantine of sorts, simply viewable outside the new system's Epic walls. My immunizations and past preventative services and care were not entered, results in a flurry of notices about tests I don't yet need. This completely shifts the burden of tracking what I need to me. My lab result trend lines all start over. My doctor's efforts to find important details in my previous records become time-consuming hunts during my already too short appointments. The experience felt not entirely different from the paper record days. This is unacceptable. While medical record portability and meaningful use requirements could have significantly relieved patients of the burden of having to remember all the details, their promise has been hampered by the silos they were designed to bridge. These experiences made me feel like my care, past and future, was less important than the integrity of these systems' electronic health records. My health system professional experience, especially working in the digital health department of one major health system, confirmed that electronic health records have the capability of integrating this and all sorts of information. It's largely a business decision, but they don't. Lesson 3. Labeling at the expense of connecting. Every organization I've worked in has a unique vocabulary. The words we use at work both contribute to and reflect an organization's culture. Healthcare is no different. As someone working to champion health literacy within a healthcare organization, I paid special attention to words and began noticing a pattern of labeling. For example, OFI, Opportunity for Improvement, was used during quality improvement discussions to describe an avoidable DVT, or blood clot. Frequent flyer was a term used to describe someone who comes to the hospital or emergency room repeatedly. Non-compliant is used to describe patients who don't follow doctor's orders, usually not taking medications as prescribed. Now, I want to be clear, I never heard these terms used in front of a patient, but these are the words that are used behind the scenes on a routine basis. What these labels have in common is that they dehumanize the person and their situation. A DVT or a blood clot is a life-changing event if you survive. Visiting the ER or hospital repeatedly is a clear sign that healthcare needs are not being met. Dehumanizing a person or situation, whether it is through labels or actions, prevents us from having empathy. On a personal note, I was labeled high risk when it came to pregnancy, and it was well-deserved. One OBGYN said, quote, "I wouldn't touch you with a 10-foot pole." He dehumanized my situation and made it about liability. Another OBGYN, in contrast, said, "It's high risk, but we can try if you're willing to accept that risk." The risk was on me, and I accepted that. Those premature twins, by the way, just got their driver's licenses this summer. So the question becomes, how can health literacy, and I'm saying health literacy in the broadest sense of the word. I don't think of it as about words. I think of health literacy as an experience. How can health literacy infuse humanity into healthcare? And I'm talking about creating health literate care experiences, ones where people feel better when they come out instead of worse. So based on these lessons, in my humble opinion, in front of this group of people whose work I have relied on for the last 18 years, I humbly offer, align the care you deliver with patients' needs. Design workflows that actually revolve around the people you are serving. Work with patients to find the best time and place to deliver information. And I'll give you an example. I recently had a family member hospitalized, 2 different occasions. On both, a consent for anesthesia was put in front of him while he was on the gurney, about 15 feet from the OR. Now, maybe that's the most convenient time for the anesthesiologist, but how is that benefiting the patient? Number 2, shift the burden of communication off of the patient and onto the system whenever possible. I call this keeping things, I'm a big Wizard of Oz fan, keeping things that belong behind the curtain, behind the curtain. Use electronic health records to their full potential. Use HIPAA and the Affordable Care Act, specifically the meaningful use requirements, to benefit patients in the way they were intended. Silos and an overemphasis on privacy create roadblocks. You would think that the P in HIPAA stands for privacy. It stands for portability. And I know I'm preaching to the choir. The checkbox mentality of the after-visit summary, one of the meaningful use requirements that was, frankly, such a colossal failure, they dropped it. I've talked to countless patients about those. The doctors can check off in the EHR that they handed it out. You know what's happening to those? They are burning up shredders and lining bird cages all over the country. 3, translate labels into dialogue in an effort to reveal the truth. Labeling someone non-compliant is a shortcut that leads to a dead end. I frankly think it's lazy. Inviting someone to share why they've chosen to not take medication starts a dialogue. Words matter. Efficiency, information silos, acronyms, and labels are things we associate with business. Empathy, continuity, connection are things we want in healthcare. Healthcare is a business, but it is the business of caring for human beings. It cannot be successful without humanity at its core. And I think we're approaching 18% of GDP at this point, and our outcomes are not reflective of that. This business is failing. It's not working. None of this is easy, I know. It takes time and effort, but there's evidence that it works. We know it works. Most importantly, a humanity-driven system minimizes the harm, the burden, and the shame that too often characterizes the status quo, leaving both patients and our providers dissatisfied. Thank you.